Hello, everybody. Thank you for joining. My name is Jody Rodney. I'm the Vice President of Marketing and Education for Plan Mecca USA. With us today is Becky Cole, and her topic is COVID-19 New Safety Protocols in the Dental Office. She just told me that she's changed this presentation about 3 times in the last 2 weeks, trying to keep up with all of the ever-changing information. So I think you guys are in for a treat as we're all trying to sort out what the new normal is going to look like as we start to open up offices again. Before we get started, I just wanted to touch on a few housekeeping items. One, all attendees are muted and you're not on camera. So if you want to enjoy yourself in your PJs and grab a coffee, feel free to do so. If you're experiencing any technical issues, please submit those via the chat. If you have questions for Becky, we will open it up for Q&A at the end. Please submit your questions via the Q&A feature at the bottom of the Zoom. That will help us work through the questions as they are being asked. And then following the webinar, we will include the CE survey link in the chat along with the AGD code, but we will also send a post-webinar email that will include a recording of the webinar as well as a survey link. So if you're having any issues with the link that we post, you'll be able to access it via the email that we follow up with. So without further ado, I'd like to introduce Becky Cole. Becky, take it away.
All right, thanks guys. I'm really excited to have you guys here. This is only my second Zoom continuing education, so webinar, so it's a little bit different than talking in front of hygienists. And so today we're going to talk a little bit about COVID-19, and I know that as everybody knows, things are constantly changing, and like Jody mentioned, I've changed my lecture probably every day. Every day I've done research, I see new things, I come up with new things. I just changed it 5 minutes before I got on with Jody. I had the opportunity to listen to a roundtable yesterday with doctors from all over the world, and everybody has a different opinion about what's right and what should be right, and every organization is regulating things differently than another organization. So I think as hygienists and as professionals in the dental field, we just have to be confident a little bit in some of our knowledge and our skills in order to protect ourselves. So I'm going to talk a little bit about who am I. So I am a mom of 3 kids, and I do education, I do clinical hygiene, I'm a program coordinator for an anatomy course here in the United States. I take courses myself. I invented a dental product about 10 years ago. I run a pharmaceutical company where we distribute products to Japanese dentists. I'm recently going to be going to school for research coordinating for a new product that I'm helping develop out of Japan. And then I act as a consultant for them and for a couple other companies. But some of these pictures are some of the most recent places that I went. I got to experience some geisha girls in Japan, and this was my most recent trip in March, right before this all broke out, to Japan. I also got to go to Israel, and in Israel I went to a partners meeting and I got to tour Jerusalem, and we learned about regenerative products and those types of things. So with my career, I've had so many opportunities to experience the world. Like I said, I've been to Boston, Japan, Chicago, Sweden, Israel, Houston, all in just 1 year. So I've really had the opportunity to kind of do everything. So today we're going to talk about, you know, this is a global pandemic. And when I did this course just 2 days ago, when I updated it, we had 3.7 million cases in the world, and we had 1.3 million cases in just the United States. And as you guys know, every day that's changing. Every day things are getting different. And so as healthcare professionals, all we can do is try to mitigate our risk and, you know, face these challenges head on in order to keep ourselves safe and keep our patients safe. And so those are some things that we're going to kind of just go over today. So we all know about SARS in 2002, and now we have this COVID-19. And what we have to understand is this virus actually is very similar to the previous virus. The virus previously in 2002, the only difference between that virus and this virus and the ability that they had to control it is when a person became symptomatic, that is when they were contagious. Now we know that with COVID-19, the patients can spread the virus even though they are asymptomatic. And so understanding the difference between why that virus was so much easier controlled than this virus is, that has a huge impact on it. However, the two viruses have 80% similar genetic makeup, and the key points between the two viruses is the S protein that's located on the outside of the virus. That S protein is that the spikes that you see in every single picture. Every microscopic picture shows this virus. And what's important to understand is we all have a virus, an enzyme on every one of our cells called the angiotensin converting enzyme 2, or ACE2. So a little bit about the coronavirus. The coronavirus, this is an RNA virus. It's an enveloped virus. From what they say right now, it was transmitted from bats to humans in the wet market in Japan. What's hard about this virus is it's so small, which is why understanding which mask is appropriate for the use to protect ourselves, we have to kind of understand that. And like I said, the distinctive appearance of that virus is the coronavirus. So it looks, they say it has the sun-like appearance, okay? And so that's where COVID or corona kind of comes in. And then the virus, VI, is for virus, D is for disease, and 2019 is when the virus was understood or found. So that's where the name of COVID-19 comes in. So we have to understand, how does this virus attack us, and why are our patients with comorbidities so at risk for this disease? And when I previously told you about the angiotensin converting enzyme, that is what makes our patients susceptible. And the reason is because cells like the alveoli in our lungs, which is the smallest cell in our lungs, is very rich in that enzyme. Well, the S receptor, the S protein on the virus, attaches to that enzyme. And so people who are on high blood pressure medications, you will see that they have ACE inhibitors. Well, the ACE converting enzyme is it is used to lower our blood pressure, right? And it helps regulate our blood pressure. So what happens is patients that are on medications that increase the number of ACE2 receptors on our cells, which makes them increase risk, because then those viruses are able to attach to that enzyme even more. So once that virus attaches to the enzyme, then it's able to enter the human cell. Once it enters the human cell, then it replicates itself, okay? And that's the RNA. It replicates itself, and then it buds off of the cell, and it goes out and creates and invades other cells. So this is how this virus is proliferating through our body. But the reason why it affects our lungs is because of the inflammatory response that it stimulates in our body. It's similar to periodontal disease. We get inflammation from, periodontal disease is a chronic inflammatory disease. People who have an unregulated amount of the immune response to the bacteria in our mouth, we get periodontal disease. Patients who get an unregulated response to this virus gets the pus and builds up in their lungs, and that's where these patients are having issues with bleeding, is because of our inflammatory response to the virus. So something else they're also finding is this virus causes the body to have unregulated or blood clotting. And what that means is patients are getting bigger blood clots. They're finding patients are actually dying from pulmonary embolisms. They're having strokes. They're having clots in their lungs, and we're also noticing that patients are dealing with issues of other organ failure. And so any organs that are rich in those ACE2 receptors, they are going to be more susceptible to this virus, because that virus, it gives that virus an ability to enter the cells. Not to mention these organs are having a hard time surviving because we are pumping them through all these different treatments, and we get kidney failure and we get liver enzyme increases. And it's just not only the virus, but also the treatments we're doing to treat the virus. So our patients who have high blood pressure or diabetes, their vascular system is already affected because of their disease. And so that's why they're at higher risk for mortality from this disease. So one suggestion that I have as hygienist is have our patients that are really high risk or very uncontrolled come in the morning. First thing in the morning, where the office has had a chance to kind of sit and air itself out over the evening. Let's talk about the transmission of the virus. So there's basically 4 ways this virus can be transmitted. First is direct contact. That's physical contact. That's the mom wiping the son's nose. That's just you touching somebody else's secretions, and then you touch your face, now it's been transmitted. The other transmission is indirect transmission. And what that means is if you touch a surface and it has the virus on it, and then you touch your mouth, your nose, that's indirect transmission. The second form of transmission is droplet contact. And so that's getting transmission through droplets. So any moisture, somebody sneezes and they sneeze on you and it goes in their face and then you breathe it, that's one that you can get. The other one is aerosol transmission, and that's breathing the aerosols that are produced from the droplets. And so we're going to go over that whole aerosol thing. It's hard because the whole idea of is this really transferred through aerosol is not 100% known or studied. So this is a chart that was in the New York Times, and what this chart displays is what professions are at highest risk for transmitting the disease. I think as hygienists, you probably already know that we are #1 at contracting this disease. And to understand this chart just a little bit, so the size of the bubbles tell us how many people are in that profession. So the bigger the bubble, the more the population does it. So there's more hygienists than there are, police officers. And so what also the chart shows, so the horizontal line talks about the risk of us contracting the disease. How many times are we put in a position where we can be exposed to somebody with the disease? And then the vertical line is how close in proximity, horizontal is how close in proximity we are to the patient. So the closer we are to the patients, the higher risk we have. We know that, obviously. So as hygienists, we are at very high risk for contracting this disease just because of our profession, but also because in our profession, we create aerosols. And so to understand the concept of aerosols, you have to understand how is an aerosol produced, right? So when we sneeze, basically those droplets, those are large. Those are larger droplets. They are going to not stay up in the air for a long time. They're usually going to come out and then drop about 6 feet, okay? And that's between a cough and a sneeze. But what happens is when that droplet is aerosolized, it makes it lighter, it makes it smaller, and actually the moisture in that droplet starts to evaporate, and then it leaves the virus, and then the virus has things attached to it like salts and proteins, which to our advantage actually increases the size of the virus, which then makes our N95 mask more effective towards it. So we'll talk about that a little bit more. But one thing to understand about this aerosol is making sure that we are protecting ourselves if we create aerosol. So making sure that if we're wearing an N95 mask, not to take it off until we've left the area where aerosols are present, okay? And so one thing that we're doing in our clinic is we're keeping our N95 on, and then we put a surgical or level 1 over our N95. So when we leave the room, we leave our N95 on, but we take off our level 1 so that our contaminated PPE is left in the room. So in order to understand how this virus is transmitted and transmitted through the office, we have to learn a little bit about that transmission, okay? And what professionals in our office are at highest risk for contracting the virus. And OSHA put out a, oh, I'm sorry, I was wrong. Okay, so we have to understand how somebody who's infected can transmit that virus throughout our office. And so somebody who's infected sneezes or anything, and it's going to go aerosolized, right? And so these are things why we're going to talk about different protocols of what we're going to do in order to prevent a sneeze contaminating the entire office. But this just goes to show how easily this virus can spread throughout the practice. Everybody's susceptible, every surface is susceptible to this disease. So we really have to understand how it can be transmitted through the clinic. So this is the chart of OSHA and what they describe every professional in the office as different risk. How much risk do you have in contracting the disease? And so some of our lowest risk staff members are going to be maybe our insurance coordinators, people who are in the back office who don't have any contact with patients, who are really not coming out. But the reason why they can get some risk from the virus is if they leave the back office, they walk down the hall, they touch doorknobs or handles that haven't been cleaned or washed, that will put them at a risk of contracting the virus. The staff members who are at moderate risk are the staff members who can be at least 6 feet away from our patients. And maybe that's our front desk staff and people who do not have, they don't go closer than 6 feet. So even our treatment coordinators who are in the other room seeing these patients, but not actually being close to close. And in our office, our consult room has been, we've moved our consult room to actually our conference room. And so now the patient and our treatment coordinator will sit 6 feet apart to do the consultation. And then our higher risk employees, those are our employees who are sterilized techs, anybody that is not in the environment where an aerosol is created. For instance, we have an assistant, we were in an ortho-perio office, and we have an assistant that's an ortho assistant. So she's not in the room when there's aerosols produced, but she is in contact, closer than 6 feet contact with the patients. And then we have our very high risk occupants or staff members in the office, and that is hygienists, dentists, and assistants assisting the doctors. And the reason we kind of have to understand what risk you're at is because it's going to determine what PPE you're going to use throughout the practice. This will then be able to prioritize the PPE that we need that are for our very high risk staff members, and then prioritize PPE for our lower risk staff members. Like our lower risk staff members, you recommend, hey, wear a cloth mask when you go out of the back office and go to the bathroom. Our moderate, ask your front desk to wear a mask, and even we have now the plexiglass in our office to protect them and making sure they're staying 6 feet away. And we've also incorporated some other protocols, but that'll come later. So this virus is really going to change the way that we practice our dentistry. We have to implement new protocols in order to mitigate the risk of contracting this virus. And we have to change our protocols, not just in the clinical area and our operatories, but we have to change our protocols for our front desk staff. So protocols have to be changed everywhere. And so let's talk about some of those new protocols that you could consider implementing. If any of you guys have seen some of the papers that have come out recently, I've seen them pop up on all the Facebook sites where people have read them and posted them, and that's kind of where some of this come from. And we've implemented, I would say, 99% of them in our clinic. So the first one, patient communication. The way that we talk to our patients and help them understand the risks that are associated with coming to an appointment is important. So talking to our patients and explaining to them, you know what, we're going to look different when you come in. We are going to have different equipment on. We're going to have masks on. We're going to have head coverings on. We're going to have full body suits. We're going to look like we're in a hazmat suit. For patients, that might feel very overwhelming, especially for our patients that are very fearful of the dentist. But I think letting them know ahead of time that this is what they're going to see, I think that's going to help a little bit with their anxiety about it. Also explain to them that treatment's going to be different. It's not going to be the same that it used to be, and explain to them why. Explain to them the risk of aerosol, and explain to them the risk that if you have patients that have high risk or comorbidities associated with the COVID-19, it just puts them at higher risk. And so we just have to change the way we're doing our treatments in order to protect all of our patients. Secondly, stagger appointments, which means we are not going to see a patient in the same room back to back. And I understand that the way that most dental practices are designed these days really limits the way that you can practice and limits your ability to separate patients. But if you can really avoid using the same room over and over for each patient, you're going to decrease the risk of exposing each patient after the next one. So also, if you can use rooms that are not next to each other. So if you have 5 rooms, use room 1, 3, and 5. Also, we're changing our appointment confirmation. So all of our appointment confirmations are going to be done over the phone. And we are going to call and do our screenings on the phone with the patient. And the idea is we want to limit the amount of face-to-face contact we have with patients and keep that distance from them. And thank goodness this time came in a time when everything is virtual. We can do everything telemedicine. We can do phone calls. Everybody has cell phones. If this had to happen in a time right now, we are equipped with the things that we need in order to do that. So our check-in. In our clinic, our patients are limited to coming into our reception area. So when they come to their appointments, they're instructed to call us. And once they call us, we will let them know to wait in their car until we are ready for them to come in. And so our reception area, we can prevent any traffic or multiple people sitting up front or coming in contact with each other. So we can really stagger the way that they come through the clinic and not have a waiting line or people in the same area at the same time. And so our check-in will be over the phone. Also, questionnaires, if they can be asked online, or if paperwork can be filled online before they come, that's definitely a benefit to reduce the amount of exposure to paper. So, or to even doing it on a computer instead of doing it on paper. So, and then office entry restriction. So what that means is patients who are coming to our practice, we don't want them to bring their whole family. It is well known that patients love to bring their family and their loved ones and their grandma and their grandpa, and those things have to change. So patients should really only come in to the clinic, the people that are actual patients, and the caregivers or the parents should be waiting in their cars. We are an ortho office, so we have a lot of young kids that come to our practice. And so we have the parent bring them to the door. The staff member goes and gets the child at the door, brings them back, does treatment, then takes the patient back to the front door. And then if Dr. Kim needs to discuss things with them, that's my doctor, she's orthodontist, we either do a Zoom call with a parent or we call them over the phone and explain things to the parent. So limiting the number of people coming into the practice. Dental staff deliveries, so dental supply deliveries. So when we have all of those deliveries of our supplies and our wonderful PPE, what needs to happen is they need to leave the boxes outside. This virus is actually very susceptible to UV light. UVA and UVB and UVC is very different, but they do say that some of the UVA and UVB light can kill the virus. You can leave it outside and let it sit in the sun for a little bit. And the heat also will help because it's an enveloped virus, remember, so it's very susceptible to breakdown. But also that prevents having those delivery people into your clinic. You have to understand how many places have they been in your city. And if they've walked in and out of all these different areas and they've walked through something and it's on their shoes and it's on their clothing, they're bringing it to your clinic. So don't allow them to bring any of the boxes into the clinic. Remove all non-essential things in your office. No brochures, no papers, no magazines, no, we don't want to have our anything really. So I have water picks. I'm a huge water pick advocate, and I had to remove that from the shelves. I have no display anything on any of my cupboards in the office, because that aerosol can get on anything, that can contaminate anything. So plus you're going to have to clean it all the time. And so if you touch it, you're at risk for being contaminated if you cannot clean it on a regular basis. So it's just best to get rid of it right now. And then we have to contain our aerosol, and we're going to go through that a lot. Aerosol is a huge topic right now, but just using the ultra dam and then really getting away from using the ultrasonic. And we'll go into that quite a bit. It's kind of a daunting thought as hygienists that we don't use our ultrasonics anymore. And then an environmental dental assistant. And what this is it could be one person that is always the same person, or every day that could switch for who's responsible for that. And it's just a person that would go through the clinic throughout the day, wiping handles, wiping pins, cleaning different areas, going in and making sure that bathrooms are clean, that handles are clean. The environmental dental assistant can be that person where if you need to get something out of your room and you have your contaminated PPE, they can be the person that's the runner, and they bring it to you so that you don't leave the room and contaminate any other areas. And so we have one designated person for that in our clinic, but nobody likes to be that person all the time. So you can designate somebody, you do it on Monday, Tuesday, Wednesday, Thursday, break it up. But what this will do is make sure that everybody's safe. And the only reason I really like giving everybody that designated job is because everybody then knows what you have to do. And they can say, they know that this person does it this day, but you're familiar on what they should be doing. So if they miss something or don't get something, you have the knowledge and the skills to do it yourself and help as well. So just the environmental dental assistant, they love the idea of an assistant just because really they're the best at infection control. So patient screening. Everybody's heard about this, patient screening. If you've been to the doctor, if you've been anywhere, you've probably been asked these same questions. And so these are the ones that I find really pertinent. My daughter was in an accident. We ended up in the hospital, and they asked me this question every single time I walked in and out of the hospital, and in the emergency room, everything. So these are the questions. One of them is, do you have a fever over 100 degrees? And, most patients are probably going to know if they have a fever over 100 degrees, but we also recommend taking the patient's temperature when they come in. We're also having our temperature taken as staff members, and we have to record it every morning and every afternoon before we leave. And we have a spreadsheet. So everybody has to come in, take their temperature, write it down before you start work and before you can leave. Okay. The next question is, have you had a fever over 100 degrees within the last 14 days? I know it seems silly to keep asking questions that are kind of redundant, but really if we don't ask patients exactly the way that we have to ask them, they're not going to answer them the way we want them to. Plus, I think it's best to really ask some questions that are not something they have to really analyze. It's yes or no. Yes or no. Did you have this or did you not? So another one that we're always screening for patients is, have you lost your taste or smell within the last 14 days? They're finding that patients can have just the loss of taste or smell and not have any of the other symptoms. But as we know, these patients can spread the virus even if they don't have any of the major symptoms. And then, have you experienced a cough or difficulty breathing in 14 days? Or do you currently have a cough or difficulty breathing? I know, once again, it's very redundant, but you know that we have to ask our patients specifically to get the exact answer that we're looking for. And then, have you been in contact with somebody who has a confirmed case of COVID-19? Hopefully that's not the case. Hopefully people who are positive for COVID-19 or quarantining and isolating themselves the way they should, but everybody may or may not understand really the severity of this. And then, have you participated in a gathering with more than 100 people? And I think that this is a really good question, because if you've been with more than about 100 people, more than likely you don't know everybody, and you don't know where they've been, and you don't know what they've been exposed to. So just asking your question and kind of screening all those different answers. Have you possibly been exposed to the virus? And then have you been outside of your local area within the last 14 days? And we all know in the United States, there are hot spots and there's spots that aren't so hot. And have you been to one of those hot spots lately? And finding out if they've traveled can really give you a good sense of, I just don't know. Maybe if you were just in New York, maybe I think it's best that we wait to schedule your appointment for about 2 weeks. And after you've kind of isolated yourself and make sure you're okay, then let's schedule your appointment. And then this seems like a really broad question, but have you been in contact with somebody who knows somebody who has COVID-19? Because we know that the person may have had contact with the patient that has COVID-19, whether it's their friend's mother, but they may not be displaying symptoms, but still can be symptomatic to your patient. And I think another question that I kind of thought about after going around Omaha and seeing all the recommendations is, when you go outside of your house, do you usually wear a mask? When you go to the grocery store, when you go anywhere, do you typically wear a mask when you go out? I think that's another important question to ask, how much risk this person is putting themselves at. So we want to make sure that some of the protocols we can initiate as a hygienist, and that is the pre-procedural rinse. And what they're recommending is using hydrogen peroxide. This virus is very susceptible to oxidation, and that's why hydrogen peroxide works, right? It breaks down this virus. Now, what they're finding is chlorhexidine is not effective against the COVID virus. This is for bacteria, which is why we use it for periodontal disease. It's not effective for COVID-19. But a lot of people are like, oh my God, you want me to swish with hydrogen peroxide? That is disgusting. You can mix it with a little bit of Listerine. And the reason why I say Listerine is this virus is also very susceptible to alcohol, and alcohol helps break it down. So you can do a little bit of a mix to make it so it doesn't seem so bad for the patients. Another thing though is not just swishing, is you want to have them gargle, but gargle if they can with their mouth shut, so that they're not putting out any aerosols when they do that. But what that's going to do is get that rinse a little bit down in the back of their throat. And then when they go to spit it out, ask them not to spit, ask them just to let it fall out of their mouth. That also will reduce the amount of aerosol that's produced in the air. Okay, so hygiene protocols, like other things that we can do in our clinic. Asking our doctors to make sure they're using a rubber dam before when they're doing their treatment. This is going to reduce the amount of infectious aerosols. Will aerosols still be produced? Yes, but there's going to be less risk of infectious aerosols produced, okay? And then using a high volume evacuation anytime we are really producing any slight aerosol. And the last thing I'm gonna say now is, no hygienist wants to hear this, but we shouldn't be using ultrasonics right now. We should not be using air polishers. We should not be using slow speeds for polishing. And you want to limit the use of your air water syringe, especially when you push the water and the air down together. The air water syringe can produce as much aerosol when you do that as your slow speed or your air polisher. So right now, hand scaling is gonna be how it should be, okay? So here's just a table to kind of explain to you where the aerosol risk is. And like I said before, the ultrasonic is the #1 risk in our clinic. We can spread these aerosols up to 20 feet from our ultrasonic. And like we all know, it can stay suspended in the air for up to 3 hours. And so what that does is you use your ultrasonic and you haven't used a high speed, and that aerosol sits in the air for 3 hours. Then you stay in the room, you remove your mask, you remove your shield, and you're in the room breathing those aerosols that are in the air for the next 3 hours. Then your patient who has blood pressure or high blood pressure or diabetes, and they enter your room and they take in that aerosol, and what's going to happen? They are now exposed to that virus. And so we have to say universal precautions. You know, you cannot use ultrasonic on anyone right now. It's a scary thought as hygienists to think that, how are we going to do this? This is just, you know, it's just really daunting to think that we have to care for our patients without an ultrasonic. But right now, we just don't know the answer. Do we know the answer if really these aerosols are infectious? No, we don't. And like I said, the information that we have about COVID-19 changes every single day. Every single minute of every day, I get something else. And so what they're saying is, yes, there is a risk of aerosols, but really we have to have more studies to know. And they say, based on some of the previous studies they had done, there's no reason not to infer that this virus can be spread by aerosols. And so the test that they did is they took Petri dishes and they spread it throughout the room, and then they performed procedures just like they would do every day. And then they went back to the Petri dishes, depending on how far they were, and to see what grew on those mediums. And of course there was growth, and there was a lot of growth that came, the bacteria was from the ones that we know in our mouth had grown on the mediums. But what's hard is that virus doesn't grow on the medium. Right now, it's very difficult for us to study how far that virus is going to go, because using a Petri dish and not using the exact medium in order to get that virus to grow, then we don't know how far it's actually going. And most viruses are smaller than some of the bacteria that we're more concerned about. So do we 100% know that aerosol is going to infect others? No, we don't. But the thing is we don't know enough to say it does not. So right now, I would err on the side of caution of saying it might infect you. So why would we risk it? This isn't going to be forever. Soon there will be research and we will know whether or not we can go back to using ultrasonics. But right now, we really have to stick to don't risk yourself and don't risk others. So how are we going to reduce the risk of getting infection from aerosols if aerosols, infect us? The only way we can do it is using our personal protective equipment, pre-procedural rinses, high volume evacuation, rubber dam with restorative, and hand instrumentation. So let's talk about right now, the ADA and the CDC have highly recommended that we reduce the amount of aerosols and splatter created in an office. So this is not just, hey, Becky says, don't use your ultrasonic. It's best not to use it. But right now, the CDC and the ADA are both saying you need to reduce the amount of aerosol that is produced in an office. And as you know, a lot of ADA and a lot of CDC and a lot of areas are saying we still should be sticking to only emergency treatment. And if we have the proper PPE and we have the means that we need to protect our patients, then we can open and we can do elective treatment. But they're still saying you should limit the amount of aerosols produced. So here we are looking down the face of, are we going to have to really scale our patients without an ultrasonic? And are we going to lose our safety rope? Are we really going to be able to do this without ultrasonics? And we have to understand, first, this is going to last forever. Soon there's going to be research. Soon we're going to know if this really is transmitted through aerosol. Like I said, I'm a research coordinator with IMAC, and currently they are doing a little bit of research. We are all getting on board to try to figure out how we can really find out what risk we are at with these aerosols. But until then, I think that we really need to look at hand instrumentation as our main means of treatment for patients. And secondly, we actually do have a safety rope. We have a safety rope, and what that is it's our education and the types of instruments that we use. So in my perio clinic, I've been working here for 7 years now. I see cases like this almost, I would say, at least weekly, cases that are this severe. And it is daunting for me to think that somehow I'm going to have to treat these patients without an ultrasonic. But I can tell you that if you are given the proper equipment and the things that you need in order to treat these patients, we can do it. And The reason a lot of hygienists are like, well, how are we going to practice without using ultrasonic scalers? Like, how are we going to make sure that we are providing standard of care for our patients? Well, we need to talk about what is standard of care right now. And standard of care is different than what we knew it before. Because would OSHA really come 6 months ago and tell us it was okay to use an N95 for multiple patients? Would OSHA have told us that we should be reusing disposable gowns when we see patients? Absolutely not. But when we are faced in a situation of we don't know and we don't have the resources we need, standard of care is different than what we've known, okay? And so we have to understand we can do the best we can. It's the same with our PPE. We can only do the best that we can. And so this study was done, and what they did is they took 3 groups of patients, and they use hand instrumentation, they use the traditional ultrasonic scaler, and they use the piezo. All the patients had moderate periodontal disease with, it was chronic periodontal disease, and the patients had periodontal pockets greater than 4 millimeters. So if you look at the data, it shows that in each group over the course of the time, the difference between what the outcomes were very similar in comparison to each instrument used. The hand instrumentation and the ultrasonic and the piezo, there wasn't a huge drastic difference in the outcome of the patient's treatment. So that should give you a little bit of comfort knowing that if you can be proficient in your hand scaling, we can give our patients the same standard of care. So our goals in hand instrumentation is really, we have to remove the biofilm, we have to remove plaque, calculus, and the necrotic cementum, right? That's what we use instruments for. And we need to create a smooth surface so we can reduce the risk of more bacteria attaching to the surface. And so really the success of hand instrumentation really depends on these different issues, but you know what? I think that we can overcome them. For instance, the pocket depth. How are we come over trying to reach a 9 millimeter probe depth on the mesial of number 3 on the root surface? And it has to do with our instrument selection. What type of instrument? How big is a blade? How thick is the blade? Instrument selection can really give us the advantages to still access these spots. The type and the tenacity of the deposit, and I think that the sharper the instrument, if a piece of calculus is very hard, you're going to be able to remove it with a sharp instrument and a rigid instrument. So you know that we have instruments that aren't as rigid as others, but using an instrument that is more rigid will give you the ability to remove that calculus. And root anatomy. Once again, instrument selection and knowledge of your root anatomy. If you really have the knowledge of your root anatomy and knowing where your furcations are and knowing all the concavities, then you are going to be able to access those areas on different teeth. And there's times when I use instruments that may not have been for that spot, but you know what? I can get it curved in there and get that calculus out of there. I'm going to talk to you a little bit about LM instruments, the LMES instruments, which are the ones that I recently switched to. They have an instrument right now that I should have got some out and shown to you, but they are at the very end of it, it has a ball on the end of it, and on the end of the ball, it has diamonds all over it. You can take that instrument and without have to make a stroke motion, you're able to remove calculus with it. They're amazing. These instruments are amazing. And so also operator skills. That's going to take experience. Some of our new hygienists that are used to using ultrasonic in schools, you know, this is going to be a learning curve for you, but you know what? You're going to come out as a more proficient hygienist when this is all over. But also knowing your anatomy. Anatomy is really knowing the anatomy of every tooth, knowing where the concavity is on your premolars, and knowing where calculus collects, you know, is going to help you adapt your instruments the way we need. But instrument sharpness, that is a #1 thing that we are going to have to focus on as hygienists. You will really risk your risks and the comfort of your patients if we're using instruments that are dull. So we need to make sure that we are staying on top of sharpening our instruments and making sure we're using quality instruments to work on our patients. So I was able to go to Sweden, and I attended a 1-week course in Sweden. And while I was in Sweden, I was introduced to the LM instruments that I'm going to talk to you guys about. And we had a hands-on course there. We had, they're not cadavers, they're like we use in hygiene school, and they had fake calculus on them. And we went through and we used their instruments and we got to try them out. And at the end of the course, everybody got to take home one instrument. And the instrument that I got, luckily, was the Sharp Jack, which you guys all know that's similar to the Montana Jack, the Nevi, let's see what else they call it. American Eagle calls it the Blackjack, okay? So I got the Sharp Jack and I took it home. And I performed an entire full mile scaling root plane with one instrument. That instrument did not get dull at all from the beginning to the end of that scaling and root planing. And my hands didn't hurt. I didn't have that cramping in my hands after doing 4 quads of scaling and root planing. And I just thought, you know what? This is going to save my career, because I had really started developing cramping in my hand and pain in my wrists. And so when I switched to this instrument, because of the handle on this instrument, I was really starting to not have as much as that fatigue that I was experiencing with my other instruments. And so these are the instruments that I currently use. This is my scaling and root planing kit that I use from LM, and this is the ES model. And what that is LM has their black diamond, and it's a coating on them that allows these instruments to remain sharp. So why did I switch to these instruments? The reason is because I don't have time to sharpen instruments. I have been doing this for 18 years. I work for a perio clinic and I am backed up for 6 months. I am scheduled for 6 months. I have to come in on my time off and my days off to see patients who need acute care. If I can't get them in and fit them in for scaling or root planing, I'll come in on my days off and see them, but I don't have time to sharpen. Secondly, like I told you, I had really started to experience fatigue using the traditional instruments that I have. I have used multiple different kind of instruments over the course of my years, and I have changed multiple times to different types of instruments. And so this was the first one that I really actually noticed a difference in the way that I felt after a full day of hygiene. And then my clinical environment. I still do practice in a general practice 1 day a week, and I practice my perio clinic 2 days a week. And when I moved to my clinical practice, my perio practice, I really struggled with these really difficult cases. And so I had to have an instrument that would give me the best outcome. The disadvantage of working for a periodontist is if you've done the scaling or root planing and that patient goes in for surgery, they lay a flap and they can see every piece of calculus you burnished and every piece of calculus that you left. And I can tell you, I'm a very competitive person. That's a very humbling experience to have your boss go in there, lay a flap, and then ask you to come in and look and see what you missed. It takes a lot to swallow your pride and say, you know what? Thank you for showing me. I can, understand better where I need to work in these areas to get them better. But I also said to him, you know what? I have to have the instruments. If you're going to cheat by laying a flap and getting to clean that root, then I better have the best instruments I can have in order to treat my patients. And so he let me switch to these instruments after we went to Sweden. And so this instrument right here, let me tell you, this will change everything for you. This is their new probe. If you look carefully at the end of this probe, it has a little ball on the end of it. The other thing about this probe is it's very thin. And in my clinic, since I've started using it, unfortunately, I have found more pockets that I had missed before because this instrument is so thin and slides so easily down into the pocket. So it's not really great for me, and it's not great for the patient, except for the fact that we can find areas that we need to concentrate on and that we need to treat. So this probe is fantastic. And when they developed these instruments, what they did is they did a lot of research on these instruments. And what they did is they took a study and they compared 4 of the most common instruments used, other instruments that were also coated, diamond coated, and their handles. So if you look over there, that's the American Eagle handle. The next one is the traditional LM handle. And then the third one over, they call it the LM prototype, because when they did the study, the ES handle was a prototype. And then you can see our traditional hue 3D. And so what they did is they have different practitioners use the instruments and then rate the instruments based on these 14 different criteria. And then from 0 to 100, 100 being a best, what would you recommend for each one of these? How did you feel based on this criteria for the instruments? And really the ES, the handle for the LM instrument, scored higher than all of the other instruments in almost every single category. And I'm not surprised by that outcome. And so the reason why this instrument, is so great, it's just the way that they study the ergonomics for this, the silicone in it. It's very, very light. And the tactile sensitivity through it is very good. I feel that I'm able to find and remove calculus a lot better with this instrument. There's times that I don't even pick up my Explorer to find calculus in these areas. And then the blade. So besides the fatigue and the ergonomics of this instrument, they used, it's a black diamond coating. It's sharpen free. You don't have to sharpen this, but it's 82% more resistant to wear. And so it allows you to have these instruments for a long time. I still have my instruments, the same ones that I bought. I haven't replaced any of them. They're just as sharp as the day that I got them. I can't say how long they last yet because I haven't had them long enough to determine, but these instruments are what I really love as far as staying in my career. I've been doing this 18 years, and sometimes I think I get up and I go home on a day and I think, I don't know how much longer I can do this. And I can say that since I've been using this, I haven't been having this problem. Now that I don't have access to my ultrasonic, things might change, but I know that if I'm using instruments that are sharp, we are going to be more effective in removing these calculus. So, on top of asking our doctors for the proper PPE, asking our doctors for some instruments that are really going to give us the ability to, give the care our patients need, it's going to be kind of hard. But even if you ask them for maybe 1 or 2 sets, and if you have a patient that is really tenacious calculus and they need scaling root planning, you can't use an ultrasonic, then just using those instruments in those specific cases and maybe saving them. That will give you the ability to have some of the instruments that you need to help do this job without the ultrasonic. This is not different. This is not, it's not, hygiene's going to change, but this is our new normal. There's nothing we can do about it. This is a new normal. And let's see, so this is that probe I showed you. It's just a little closer up of that tip, but it's a fantastic instrument. Okay, so what other things can we do to make ourselves safe during this COVID-19? And that is our PPE. So you hear so many things about these masks. What's an N95? What's a KN95? What's a FFP1? What does this all mean? And who do you believe? Do you believe this article or that article? Do you believe what your boss tells you? Who do you believe? And I can tell you that even when I wrote this lecture just shortly, things have changed. But some of the personal protective wear that we just have to say we have to have are, we have to have the proper gloves. We have to have a gown that's going to protect our clothing. We need to have our N95 masks, our goggles, and our shields. Now, I know a lot of you are like, I can't get a hold of these things. Where am I supposed to find these things? Well, one thing I got, so the mask there on the lower right-hand corner is called Mask On. This is an organization that is providing these ventilators to healthcare professionals at no cost. All they're asking for is a donation, okay? And I went to the website, I filled out the form and asked to get one of the masks. Within 24 hours, I had an answer and my mask is on the way. And so I'm going to be able to use this respirator. And all it cost was my $50 donation I chose to give the organization so that they can continue to provide masks for other people. Now, the disposable gowns, we know those are really hard to get a hold of. And so what we've decided to do in our clinic is we are buying the gowns that are not disposable. They are knee length, and they're kind of the barrier resistant. So they're a material that is not going to soak in the blood and the aerosols. And what we did is we bought one for every single patient. I see about 8 patients a day. And so for every patient, I will take that off, and I'm going to have a trash can in the room with a trash bag in it. I will take it off between every patient and put it in the trash can. And then the next patient, I will put on a clean gown, and I will see the patient, because we can't get a hold of these gowns either, and we're a surgery site. So that was one option that we came up with. As far as our pants being exposed, the choice that I've made is I will either change my pants between every patient, or I plan to wear the same set of scrubs in the morning, and then before I go to lunch, I'm going to change my pants. So I have a clean pair of pants on when I go eat lunch, and then I will work the rest of the day in that same scrub pants. And at the end of the day, I will remove all of my clothing and take it off and take it home and wash it. Now, I am currently not seeing patients. My clinic is open. My boss has decided that it's best that I wait for 2 more weeks until we kind of see how things are playing out. We've kind of done what we call soft opening at this time. And so right now I'm not seeing patients, but I'm getting to be a part of creating these protocols in our clinic. And we are getting ready to put a washer and dryer in our clinic as well. So I won't be having to take this stuff home with me, but if you do have to take it home, like I said, put everything in a trash bag, take the trash bag home. If you put it with your wash, do not launder it with your kids' clothes or your other clothes, and wash it on hot water. This virus is very susceptible to detergents. It's very susceptible to bleach. So if you wanted to put bleach in there, unless you have white lab coats, we know that it's going to trash your clothes. But they do have, I think it's Lysol, makes the sanitizing detergent, and they have shown that that's very effective against killing it. Now, if we could find it, that would be great, but it's a good option for laundering that stuff. Okay, so masks. I've never felt so overwhelmed when I'm trying to understand something, because it's so important. But understand the difference between a level 1 mask, a level 2 mask, and a level 3 mask. Like, what is this and what does that all mean? Well, ASTM is the standards that is used to try to standardize these masks, okay? And so what ATSM is, they have five different criteria that they use to standardize these masks. And so it's fluid resistance. How much fluid is able to reach from the front of the mask to the back of the mask? And then filtration. So it's the bacteria filtration and how much bacteria is able to get through the mask when it's tested. And then the other one is particle or subparticle filtration. So how much particle is able to get through the mask. And finally is the delta P, which is the breathability. So a level 3 mask is going to be harder to breathe through than a level 1 mask. And then flame spread, which really has nothing to do with us. So unless you're playing with fire in your office, I don't think you're going to have an issue with that. So the next one is our N95s. And I know that they're hard to find, and what we have to be careful of though is fraudulent N95 masks, and making sure that we look and see where these masks are coming from and if they've been tested and certified. And at the end of the slide, I'm going to show you a site that you go to, and it will give you, you check the labels on your mask to find out if they are approved masks or not. And so everybody's like, well, I can get these KN95s. What's a KN95? What's an N95? What's a FFP1? So to understand the difference between the N95 and the surgical mask, you have to understand that they are tested at different standards, okay? N95 masks are tested with the MIOSH standard, and the surgical masks are tested at an ASTM standard. And one thing that I read is if a surgical mask was tested at the same standard that the N95 mask, an surgical mask level 3 would actually only be as good as 70%. Now, I was at a roundtable yesterday with over 15 different worldwide dentists, and some dentists are saying, yeah, but if an N95 is not fit tested and it doesn't go on right, it's not any better than a level 3. That might be the case. And the reason why the level 3 may not be as good is because the gaps on the side. And so we all just have to make our own judgment call. But here's a little something to try to explain to you the difference between the N95 and the KN95s. The N95 means that it's a mask that came from the US, okay? N95 is the US standards for testing of the mask. KN95 is a mask that's come from China. It's been studied by China's standards. And then the FFP1, that means that mask has come from Europe, okay? And so that's going to give you a little bit idea of, okay, what does the FF mean? What does K mean? What does CAN mean? What is, you know, it's very confusing. So you can use this table a little bit, and what it does is it just kind of shows you the difference between the different masks, where they came from, and how they're tested and how well they test. So one thing that we talked about before was, though, is the COVID virus is only 0.1 microns big, and these masks are tested at 0.3 microns. Well, when we talk about aerosols and we talk about droplets, which with a mask, we're trying to prevent aerosols, and of course we're trying to prevent droplets from the fluid from touching our face and being stuck on the mask. But the aerosols is what we need to be concerned about because they're the smallest. But the good thing is if any of this is good, but the advantage is when the water evaporates from the virus itself, what it leaves behind is protein and salts. So when it's attached to the virus that has protein and salts, what it does is it actually makes the virus bigger, which makes the ability for these masks who are tested at 0.3 microns to be able to filter those masks, filter that virus. So this is the website that you can go to. It's the CDC website, and what it does is if you have an N95 or a KN95 and your boss hands it to you and say, okay, this is what we're using, I got it from eBay and I paid $50 a box, you can take that box, you can go to this website and you can check and see whether or not this mask is a regulated mask or it's fake. And unfortunately, there are a lot of fake masks right now. People are taking advantage of the fact that there aren't masks out there, and they are selling these masks that are not fake. So using this website is going to help you make sure you're using something that is safe. Okay. So surgical masks versus N95 masks. This is kind of, it's going to tell you what level of filtration you're going to get. And the biggest thing is we have to understand is it is true that our N95 masks should be fitted, and they should fit properly in order for them to work. I am terrified to start working with one because I am very nervous about not being able to breathe. I'm very nervous about having that feeling of almost suffocation. But if we can test these and get them fit tested correctly, I think that over time we can adapt to it, just like a swimmer. A swimmer will swim, and a swimmer at first is able to swim underwater for maybe half a lap, and then over time they're able to swim a full lap without oxygen. And unfortunately, this is a time where we're going to have to allow our bodies to adapt to this, the way that we're practicing. Practicing without, having that type of oxygen is going to be difficult. We're going to be tired at the end of the day. It's going to be more daunting, but I can tell you that it's what it is now. There's nothing else we can do about it. And all we can do is say, you know what? This is our new normal. This is our new normal until we have more research. This is our new normal until we have better studies and we know exactly what we can and cannot do that's going to cause risk to ourselves. So our gowns. So putting on our PPE properly is also going to protect us, because if we are taking off our PPE and contaminating ourselves as we're taking it off, then there's no point in wearing it, right? And so the main thing is you can use this flyer from the CDC and say, I'm going to follow, the way CDC says to put on my PPE and take off my PPE. But what is more important is that you establish a sequence in how you put your PPE on, and you establish a sequence on how you take it off. It should be done in a step-by-step process. It should be very deliberate, and you should be doing it exactly the same way every time, putting it on exactly the same way and taking it off in exactly the same way. And what this will do is provide just the training. And, you know, if we can be systematic about putting our PPE in and taking our PPE off, we are going to be safer. And so I would recommend, you know, you and some other staff members do some training and train on how you are going to put it on and train how you're going to take it off, and doing it exactly the same way every single time. So, other things that we can do to try to stay safe is just kind of our office setup. And as you can see, so this movie, we moved in our new dental practice in December. Before the practice that we moved into, it was an open concept practice. We had 4 chairs and everybody was exposed to everybody. But Dr. Miyamoto, my boss, he teaches in Japan, and we teach in Japan, and we teach a protocol called the medical treatment model. And what we believe is every patient should have a private room. They should have privacy so we can talk to our patients and connect with our patients. And so this is my room here over there on the right-hand side. And I am so grateful that when he built this practice, we have separate rooms, and I'm so grateful that we have doors that we can shut. So if you have that ability, if you have the ability to shut doors behind you when you're doing your work, I highly recommend it. I also highly recommend, if you have the ability to work out of 2 separate rooms, you should work out of 2 separate rooms. Using some extra oral suction devices in order to manage the aerosols with a high volume evacuation should be used. If you can get a hold of a HEPA filter in order to use it during your cleanings to try to keep the airflow moving. One thing that I learned last night at the round table is dental practices really are not regulated on how they're built. The people who come in and sell chairs and design the office don't really think about a pandemic. They don't think about exposing the whole office to aerosols. And so other things that we can do to keep ourselves safe is forehanded dentistry. If your doctor is willing to hire you an assistant to use high volume evacuation, that would be the best fit for really this situation, taking care of all those aerosols. So high volume evacuation. If we're producing aerosols, there is no reason we should be using our low volume evacuation. It does nothing. It will not remove the aerosols in the air. The only way that a high volume evacuation will remove the aerosols, if the bore size, which is the hole from the evacuation, is large enough to remove the aerosols. They say that the high volume evacuation can remove up to 90% of the aerosol in the air. So that is going to be huge in reducing the amount of aerosols that we are allowed to escape our area. So if you refuse, you know, if you say, I have to use my ultrasonic, then you really, really, really should be using a high volume evacuation. And currently there's several models on the market that you can use and you could try to help assist using the high volume evacuation. We all know that it's very difficult to use it. Just make sure that you use your judgment when you're looking at all these devices. How big is the actual bore size? How big is each hole that is on these devices that can allow that much air to go through it? The device up on the upper right-hand corner is called the ErgoFinger. This is a device that's only in Finland right now. I am currently in works trying to get this product to the United States. As an inventor myself, I invented a product myself, the eProp. Trying to sell that all over the world and follow FDA regulations, it makes it very difficult to get things into this country. And so hopefully, I'm hoping that soon we will have access to this instrument, to this suction. It's very easy to use. So we only have a couple more slides, a couple more minutes here, guys. Hang with me. We need to talk about disinfection. And so understanding the difference between disinfection and sanitation, okay? Basically, disinfection, it kills 100% of pathogens, and it's designed to clean and kill germs. Sanitizers are just for killing. It just kills the virus. They don't usually have cleaning agents in them, which means they don't have perfumes, they don't have soaps, they don't have anything. So in order to sanitize something, you must clean it first, okay? And so we typically use sanitizers, or disinfectants. And so in order for a disinfectant to work, we have to have a disinfectant and we have to use it properly. The next thing is, well, have we tested sanitizers? Do we know which one works for this virus? Currently, we don't. It has not been tested. But what they say is if it kills a virus that is stronger than COVID-19, it should kill COVID-19. And the reason why we can infer that is because we know that COVID-19 is an enveloped virus, which means it's very susceptible to break down from different agents. And some of the agents that it's susceptible for breaking down is ammonium, quaternary ammonium, ethanol, which is our alcohol, sodium hypochlorite, which is bleach. And then, so these are some of the cleaning solutions that we can use to clean it. The key though is killing the bacteria. It's not about necessarily how much time we spent wiping the device, it's how long we leave it moist. We need to be leaving the disinfectant on the surfaces for the recommended time that the manufacturer has. So I know that a lot of us are going to be using the Sanicloth or the Cavicide, and you need to look on the back of that and make sure that you look and see how long does that surface need to become moist. Because this virus can live on some surfaces for up to 72 hours. And so we have got to make sure that we give the chance for that disinfectant to really work and get rid of the virus. So some guidelines that we should be doing in our rooms when we are seeing patients. So the first one is between patients, we need to be running our air water syringe for 20 to 30 seconds. Okay, so every time you see a patient and before you bring in another patient, you need to run run the water through your air water syringe, making sure none of that stagnant water stays in the device. Second, running cleaning solution between our suction lines between patients, making sure our patients do not close down on the suction so they can get backflow. Or using these backflow prevention valves. That's the picture on the lower right-hand side. That's going to prevent any of that backflow going into the patient's mouth and letting them and contaminating them, and making sure that we are running that solution between our lines. So we're making sure to make all of our lines clean and sanitized as we can. And also, if you haven't opened up your clinic yet and your clinic has been sitting there shut for 6 to 9 weeks, my recommendation to you is going in the day before you see patients, running your lines, shocking your lines, and making sure that your lines are clean and able to run. The other thing is going in and testing our suction. The last thing you want to do is go back to work, sit down with your first patient and your compressor. We all know how touchy those darn compressors are, and making sure that they're running, change your filters on your compressors, but just make sure you run the water through your system. This water has been sitting in our lines for over the 6 to 9 weeks. And then barriers. We're going to be using a lot of barriers in the clinic. As you saw my room, I've got monitors. I was supposed to have a TV. They're not going to put it up right now. So barriers on any surface that has a lot of crevices that you're going to have to wipe down routinely, using a barrier over that, trying to keep the amount of aerosols that gets in those areas, just to keep those areas less contaminated between patients. And it makes your cleanup a little bit quicker. Secondly, all instruments need to be stored in either envelopes or they need to be stored in sterilization material. So all of those instruments, after they're sterilized, they need to stay in the bags, and they need to be you need to wait to open them until that patient is back in your room. And really, if you think about it, if you haven't cleaned the room and you used aerosol, if you haven't cleaned the air in the room, the aerosol, and you open up that instrument kit, you just expose that instrument kit to that aerosol. And so for me, my boss bought me a HEPA filter, and he also bought me a UV light, and I'll be working out of 2 rooms, and I'm going to have an assistant. And so I will be seeing my patient, and she will be doing all the charting for me, so I won't be touching my computer. All of my kits are in the central sterilization area. Anything that I would think that I need to get into when I'm seeing a patient, until I get my UV light. I won't be opening drawers while I have patients in my room, because if I open a drawer and the aerosol gets in the drawer, you contaminate everything inside that drawer. So everything's going to be in the main sterilization area. My assistant, the environmental assistant, if I need her to bring me something, will bring it from the sterilization into my room, opposed to opening cabinets and doors. So we need to make sure we are taking our slow speeds off. If you choose to polish between patients, currently I won't be polishing my patients at this time, but if you choose to use your slow speed, those need to be sterilized between each patient. And then countertops should be completely clean, no display items, keyboard should be clean, and mouse should be covered. I have a laptop that folds over into a tablet instead of using a keyboard. And then if you have a keyboard, you can just use a tray cover over it and cover up your keyboard that way. Patient napkin holders. I think that is one of the biggest things that we kind of look past as far as some of the equipment that we put on our patients. And so you can purchase disposable patient napkins, and you can also purchase napkin holders that can be sterilized. Okay. And then our wiping technique. We need to go back to our infection control days and use the technique that we were taught. And we all know what that technique is. It's a spray, wipe, wait 3 minutes, let it stay wet, spray, wipe, wait for 3 minutes. And so this is what's really going to be important when we're staggering our appointments and providing enough time between patients in order to make the appropriate disinfectants work the way that they're supposed to, and giving us time to clean all of the areas that possibly can be contaminated. Okay. So lastly, what are we going to do about this aerosol? So if there is aerosol created in your room, how do we take care of it? How do we clean it? And one thing that we can do is use UV lights, okay? And like I told you before, there's 3 forms of UV lights that the sun produces. There's UVA, UVB, and UVC. The UVC light has to go up to 250 nanometers, but there's some important things that you need to know. If you turn a UV light on in your room, you cannot be in there. Secondly, if like us, we have a door and it has a glass, we are getting that frosted because you don't want to be looking at that light. And we have the advantage of putting it in a room, shutting the door, and walk out. You don't necessarily have that advantage. But there are some great other options that you can do. It's fairly inexpensive, comparative to creating a negative pressure room or something else, but a UV light can be added into the HVAC system, or you can buy a HEPA filter that has a UV light within it. And what that does is it pulls the air in, it runs it through the UV light, the air is then sterilized, all of the virus is killed, and then you've created fresh, clean air. The hard thing about UV light is it really depends on how big the room is and how much time is required in order to sterilize the room. And so every UV light, the manufacturer recommendations are different. You kind of have to go by what they recommend. But unless you have all of these options to reduce the aerosol and kill the aerosol, like I said, until we really know if aerosol is infectious, we need to make sure that we are not using ultrasonic and not producing that aerosol, because we have to really protect ourselves. And so that's the end of what I have to provide for you guys today. But I know, when this all started coming out, I thought, oh my gosh, I am terrified. I am so scared to go back to work. Should I stay in this profession? Should I leave this profession? And, I came back the other day and started rescheduling my patients and talking to them on the phone. And I thought, I can't leave these people. I miss these people. I want to see these people. I've been seeing these same people for 7 years, and I don't want to walk away from this job. I want to stay in this job, and I want to continue to see these people. And so, you know what? This is just our new normal. That's just it. We just have to continue to do what we do. We are some of the best infection control people in the world. And so we are trained to do this. We can survive this. We can really continue. I get questions all the time. My boss is asking me to come back. My salary's been low. We just have to talk with them, be upfront with them. We have to say, you know what, I want to be safe. Just, give them the recommendations that we said today, and establishing some of these protocols will really help you stay safe. And like I said, our waiting rooms may not have to be closed forever, but for right now, until we really know, they need to be closed. And, you know, it's the new normal. It's not the forever normal, but it is the new normal. And, you know, when HIV came out and TB was out, we had to change. All the professionals had to change, and there was a scare, but they persevered and they made it through it. So I think that as hygienists, we can do that. We can persevere. We can make it through this. We can continue to be with our patients. We can continue to see our patients. So I hope that I provided you guys with some new information. I know a lot of this you probably have heard, you probably research yourself, but if there's any questions I can answer for you, I'm happy to answer them for you. So I think that Jody's going to open up questions, I believe.
I am. I'm posting the CE survey link real quickly in the chat feature. There are a lot of questions. I tried to answer a bunch as we were going, but one topic that wasn't really brought up that was an interesting ask was whether or not you're limiting intraoral x-rays, bite wings, full mouth series, potentially leveraging extraoral bite wings.
Yeah, so actually we are, in our clinic, we are limiting intraoral x-rays. We have the advantage that our clinic is attached to actually, it's called ImageDent. We have a CBCT machine, and we also have a panel machine and a SEC machine. And so we have the advantage of using, you know, taking advantage of that. But studies have said that, you know, if you have your patient and you induce coughing, that is, you know, you saw my slide in there where it showed how fast a molecule can travel when they cough or sneeze. And so if a patient chokes or coughs or sneezes with intraoral x-rays, they're just recommending to limit that if you can.
Great, so. Thank you. And one thing I forgot to mention is that we will be sending out a post, I think I put it in the chat, but we will send a follow-up email that will include a link to the CE survey as well as a recording of the webinar. There were a lot of questions for folks asking for that as well, so thank you. Mm-hmm. Somebody asked about the number of patients you'll be seeing per room and how much time are you going to put aside for disinfecting between patients?
Like I said, for me, I know how spoiled I am, but I get an hour per patient, but I have 2 rooms to work out of and I have an assistant. So when I walk out of my room and after I've removed my contaminated PPE, she'll be the one that's going to clean that room, and she'll be the one that'll turn on the ultraviolet light. So then I can go down the hallway and I'll see my next patient. After she's done cleaning, she'll come in and chart for me. And so that's kind of how I'm working, where I'm going to get an hour between patient. But that also allows the time for my ultraviolet light to kill the aerosols in my room and my HEPA filter to work. So 1 hour per patient staggered between 2 rooms.
Got it. Okay. If anybody answered yes to the screening questions, how long should they wait to see them?
2 weeks, or if they develop symptoms, then they should not come back until 72 hours till their last symptom of the virus, or if they've tested tested negative. If they've been tested again and then they get tested negative.
Okay. And then there were a lot of questions about the face mask with the donation. Can you repeat the name and if you happen to know the website?
Yeah, it's called Mask On. It's Mask On, I believe, .org. Sorry, I'm gonna get my phone and make sure I say that right.
Yeah.
And so I haven't gotten mine yet, but what I've been told is that mask is actually, yeah, maskon.org. But I haven't got mine yet, but from what I've been told, they're actually very lightweight. They're not very heavy, and I've been told you can actually breathe in them a lot better. So I have, my boss got me one and then I ordered one. So in between patients, when I walk out of that room, I'm going to leave that mask in that room to be sterilized by the UV light when I go to the other room, and then I'll use a new mask that was previously sterilized by the UV light. So that's how I'll use it.
And do you have any recommendations for the UV light or HEPA with UV?
You know, I don't have any specific ones. I did a lot of research. There's a lot of different ones online. You know, what's really hard is that supply chain. Getting a hold of them is really difficult. I know we have 6 of them that we won't get till the end of the May. And then he did find 2 of them that he's able to get sooner before I start seeing patients. But you just want to make sure that it has a 254 nanometers for the wavelength, because that's going to be the difference between the UVB and the UVA light. And also, if you have UV light that is at a wrong wavelength, you can produce ozone, and actually ozone is dangerous. And so just doing a little bit of research, asking some questions will help you get the right UV light. So.
Great. And then I think there were a lot of questions kind of about proper storage and or disposal of PPE, and whether or not things could be reused after they sit over a period of time if they don't have the ability to do in-house laundry or have a laundry service. Okay, so N95 masks, we have a small, it's about that big, if you can see, it's about that big, about a foot by about a foot, and it's a UV light. So our N95s, we were very blessed. We got a ton of masks from Japan, actually. But we still are going to limit the amount that we use, but we put it in the UV light. So after you use it, you can put your N95 in the UV light and sterilize them that way. But I don't know if I said this. One thing that we're going to be doing with our N95s is, so putting on your N95 and then putting a level 1 over it, so that all the droplets go on your level 1, your level 3, and so that you continue to keep that N95 on the entire time you're in the room, right? And then you just remove your level 1 when you walk out of the room, because you don't want to walk out of the room with any contaminated PPE on. So, and then something I learned yesterday is the disposable gowns. Todd Shire said that they call their manufacturing company, and some manufacturing companies say that some of the disposable gowns can be washed up to 5 times or autoclaved 5 times. So you just need to call the manufacturer and see if they can or cannot be. Great. And then a couple more questions about how to rinse after hand scaling, like what the recommendation would be for rinsing. Well, make sure you use just the water. Don't use the water and the air. This is something that I have also thought about, like, how am I going to manage this? And I think it's going to be, you know, giving my patient a little bit of water, having them swish, and then suctioning it out. So like I said, you want to prevent that whole spitting, anything that is forcefully putting water out. So, you know, when we use our hand water syringe, just use the water button. Do not combine it with your air button. So, yeah. All right. I see something here real quick. It says, what happens to patients who are taking ACE inhibitors as a medicine to treat high blood pressure? Actually, taking the ACE inhibitors increases the amount of the angiotensin converting enzyme in their body, because that's what regulates your blood pressure, and that's what those medications do, is increase the amount of enzymes that are in your body, and that's why it makes them more susceptible if they are taking certain blood pressure medications. Great, thank you. Yep. Several questions about the open concept and how to limit and or prevent the contamination across rooms. Somebody asked if they should be putting up, plastic barriers, or if there's any recommendations on that specifically. I wish there was the easy answer for that. I've thought about myself. I thought, man, if we can put, the plexiglass that we put up in front of our people in the room, but this virus is so small, it's going to go everywhere. So, all you have to do is work as a team to making sure that you're not, causing viruses or creating viruses. Really talk to your doctor about the concern about him making sure to use rubber dam, and that his assistant's there to use high volume evacuation. Making sure that you're not the only hygienist not using their ultrasonic, that every hygienist is on board with you. It's just the way it has to be. Well, thank you so much. We've had about 20 minutes of questions. I wish that we could answer them all because I think they're all great. But Becky, thank you so much for your time. Do you have a website or a resource or anything where people could go if they have questions or?
I'm going to be opening one. I do have a Facebook it's called Smile Superstars. So if you want to reach me there, you can go there. And I'll be opening that up just a little bit more. And so, or you can just go to Messenger on Facebook if you want to message me. And I can send you an email, Jody, if they want to email me some questions. I can do the best I can to answer them. And like I said, you know, all the information that I gave you guys today, it could be changed tomorrow. Tomorrow they could come out and say to you, you know what, this virus is not transmitted by aerosol. Everybody go back to ultrasonics.
Yeah.
But we just don't know right now.
It's a crazy world with lots of information every day.
Yeah, it's our new normal. New normal.
Right. So thanks again for everybody. If you have submitted the CE survey and you're waiting for your CE verification, it should come to you in your email. If you're not seeing it, make sure you check your spam or junk mail. But again, we will be sending it out via email as well. So thank you all. Have a great weekend. Becky, thank you for your time.
Yep. Sorry I went over, guys.
All right, take care. Thank you.
Bye.
Bye.